Good morning, everyone. Today is a, I think it should be a historical day in history of IAPC. That today we are going to fuse two different communities of the country. One, there are there are people. I should call them a jewel of this country. Those who are working since last 4 decades, all over places in the NGOs, in private hospitals, in their nursing homes, in the government hospitals. They are the. Can you mute your mic, please, everyone? Nisha, please mute everybody's mic. So they are the one who are working all over country and practicing palliative medicine and doing their best as as best as possible in various scenarios. And then there are students, those who are those who are working in 3 different centers of the country, and hopefully in this year we should have 10 more centers. So these students are the MD palliative medicine students. So this is a very unique opportunity for students to interact or connect with the palliative care physicians from all over country, because otherwise they will connect only with the palliative care people, those who are there in their hospital. And I think that it was required that they should know the whole country, that what exactly going on in all over the places and who is who in the country. So this is why we have created this IAPC Academy, and we will do our best to make it very interactive and very innovative way. Any faculty can find any innovative way if they want to do in their teaching. They are most welcome. But we will also like that all the faculty members, those who are present over here, that they will be in restrict to the time, so that we will have more and lot of interaction. Nisha, quite a noisy this thing. People have not muted their mic. So we will like that lot of interaction and practical questions students should ask. And I request everyone that we will give preference to students and young palliative care physicians, MDs, senior residents, those who are working in various places, and people, those who want to ask, they should ask questions on the chat box. Anuja will Anuja will select the questions, because there may be 3 or 4 questions which have the same answer. So Anuja will select the question and will pass over to Dr. First speaker. Now I have another very I think I am honored, Dr. Rajagopal, and I am overwhelmed that today I am introducing. I think this is the first time I am introducing Dr. Rajagopal in my life. And when I was searching that, I just thought that I should not ask Dr. Rajagopal his biography. I should search in the Google. And when I was searching, I think I was amazed to see Dr. Rajagopal, your biography. My God! So this jewel of this country, who has started palliative medicine, and we consider him as father of palliative medicine of India, was born in India on 23rd September 1947. And he started, I will not go into the detail because otherwise 1 hour will go. Anuja has asked me to take only 5 minutes. So he started his palliative care, this thing in Calicut, uh, and he has innovated in his innovative way. He has developed palliative medicine all over country. Although now various people are doing various things, but ultimately the seed of the palliative medicine was sown in this country by Dr. Rajagopal. Dr. Rajagopal has a lot of achievements, lot of awards, lot of honors, but one is which is definitely I would like to emphasize, give the information to the. I think everybody knows about this contribution of palliative care scene in India. But in 2018, even Government of India first time recognized palliative medicine and honored Dr. Rajagopal with the Padma Shri Award. When I was when I was seeing his various position held in the all over the world, he is not only famous in India, but all over the world he has got almost 10 odd positions which he is already taking care of. I don't know how he is handling all these positions. The main position which is handling in this country is right now is chairman of Pallium India. Besides this, is director of WHO Collaborating Center for Policy and Training, on axis of pain relief, and he is member of Elizabeth Kubler-Rossler Foundation, and then he is commissioner of Lancet Commissioner on Global Axis of Palliative Care and Pain Relief, and then again he is Commissioner Lancet Commission on Value of Death from 2019 onwards, and so on and so forth. He has got multiple awards. I think there is a list of awards. It is, I will not go into the detail, but definitely a person from palliative medicine, first time recognized by Government of India, and we are honored and we are very privileged, Dr. Rajagopal, to hear you. Everyone is waiting, students are waiting to hear you, and we are privileged to start this IAPC Academy with the first lecture of Dr. Rajagopal. Dr. Rajagopal, then now it's over to you. Thank you very much, Dr. Rajagopal, for accepting my request and being with our students. And I'm sure they will be privileged and they will get a lot of things from you in 1 hour. Thank you very much.
Sushma, thank you. Sushma and everyone who thought up this program and made it happen. Congratulations on your this innovative thinking. And I am glad this is happening, and thank you for this opportunity. With your permission, can I request Nisha to share the screen now? In our country, our culture, we have this feeling that we should start by respecting our gurus. So I will start by remembering some giants whose shoulders we stand on. I'm sure all the MD candidates would know them, but just in case some of the new entrants to the field do not know them, let me introduce. Nisha, are you sharing the screen for me? I am not empowered
Yes,
to the...
Yes, sir, she'll do it.
Sir, I am doing it. In a minute, it will be visible.
So, while Nisha is getting ready, I was planning to start by showing you an image that you have all seen, that of Dame Cicely Saunders, the founder of the palliative care movement. And then I'll show you the second picture is that of the real father of palliative care in the country, Dr. Lucito D'Souza, who in 1985 built the first hospice in the country after his visit to St. Christopher's Hospice. And this happened at a time when I had not heard the words palliative care. I also, okay, Nisha, will you put it on slideshow and then go on to the next and the next?
Yeah, okay, sir. Okay.
No. Go back and go to slideshow. Slideshow,
yeah, it's
please.
on slideshow, sir.
That's strange. Okay.
Put it on slideshow. It's not. Yeah, now it.
Okay, next slide. Move the slide, Nisha.
Yeah.
Cicely Saunders, one by one, please. Now that's fine, as it is now. That is Dr. D'Souza, who is an oncosurgeon from Mumbai, who still lives in Mumbai. And Miss Jilly Byrne, who lives in Oxford now. In the 1980s and 90s, she toured all over the country, talking about palliative care to anyone who would listen, because she could not bear to see the suffering in this country. Nisha, next one. Dr. Robert Waycross, who used to come to India for many, many years, twice a year, and would spend 1 month each time traveling all through the country, teaching most of us, the first generation palliative care people in the country. Next, please. Dr. Jan Stensward, the former chief of cancer and palliative care at WHO in Geneva, who loved India loved our people, and who did a lot to promote palliative care in developing countries. The person who initiated the activities for the WHO ladder. Next, please. Ms. Valhankin, a nurse. Sadly, she is no more with us. She died of cancer. Who was the person who taught communication skills again to most of us, first generation palliative care people. And finally, next please, Mr. David Joranson from USA. He lives in USA now, who took it as his job to analyze drug policies. We would not have had the access to morphine that we have today if he had not analyzed our complicated law, instructed us how to go about it, how about to change it. So, ladies and gentlemen, after introducing these 7 giants, there are many more to talk about, including Dr. Bhatia in Ahmedabad, who pioneered pain management and whose the picture I could not get. We have a lot to thank for. And with that introduction, I am moving on. Nisha, next one. But before I go on to talking about Nisha, talking about intractable pain, let us be clear about what our objective is.
1 minute, sir. I'm doing.
Our objective when treating pain is not freedom from pain. It's much more than that. Our objective is to reduce suffering. I know that this is not the WHO definition. The WHO definition still holds true. 18 years old. Attempts at revising them have not succeeded so far. But essentially, I hope all of us will accept it as our responsibility to make sure that we are always trying to prevent and treat all serious health-related suffering. Not only end of life, not only cancer. The disease should not be a criterion. Not only chronic diseases, humanitarian crisis, COVID-19, the bus accidents close to your city. Wherever there is suffering, we should be stepping in and trying to relieve that suffering, and freedom from pain is only a part of it. Thank you. Nisha, next. And we'll remember that though today I'll be concentrating mostly on the physical aspects of pain, I want to make sure that we remember that our objective is quality of life, for which social, spiritual, and emotional issues all will have to be addressed. Will you go on to the next one? And that's the concept of, Nisha, that's the concept of total pain. Nisha, I suspect that it may be better if you make me the host and let me use my own screen. With that introduction about total pain, I will now go on to pain management. Many terms in pain are defined officially by International Association for Study of Pain, but intractable pain is not one of those definitions. So, I mean, okay, I can take some liberties with it. When I talk about intractable pain today, I am talking about all those who do not get adequate pain relief with the WHO ladder. And unfortunately, simple application of the WHO ladder is usually successful in only about 3/4 of the patients in pain. 1/4 do not get satisfactory pain relief, unfortunately. So mainly we are talking about those people who continue to be in pain even after we have made our given them our usual armamentarium. Next, please. I shall mention 3 points in which we'll have to prepare ourselves. 3 points then to remember, and finally 4 points with drug therapy. So organized into 3 groups. The first 3 points are believe the patient about the pain. This each one of you has heard 73 times, but still we sometimes tend to forget. The patient keeps on saying that I don't have pain, I don't have pain. And then sometimes we start dismissing them. Oh, it must be also pracortical. Forgetting that even if the cause is emotional, it's our job still to find the reason and to try to treat it. Secondly, a common complaint against palliative care doctors, against palliative care as a whole, is that we can be the cause of denial of treatment. And I have heard this, I mean, I have even had this openly told to me at a meeting. You people keep on giving pain relief and the disease gets incurable. We will have to remember that though that may be an exaggeration, we do often forget definitive forms of pain relief like treatment at the cause. If the patient with cancer pain comes to us complaining of chest pain, every time we have to see them. The cause may be a new pleural effusion which needs to be tapped. The bone metastatic pain responds best to radiotherapy. So correcting the correctable certainly is an important part. Nisha, can you go back? I have forgotten what the third point is. That was a bit too fast for me.
So going back.
And very commonly, we fail to check whether your prescription has actually been followed. We keep on increasing the medication. The patient may not be taking it the way you want it. And look at that picture that I have shown there. Dr. Nirmala had a patient who is in command. Very clearly, she is leaning forward, listening with respect to the patient. And that's important. See, hey, are you taking the tablets regularly? The patient will just say yes, sir, or yes, madam. But that voice of authority is not what we need. Instead, we'll have to tell them. It takes a couple of minutes, but they are essential. Tell me, how many times are you taking this tablet? Okay, 5 times. Okay, tell me, when do you take the first one, second one, third one? And then will come out the truth that they think it is 4 hourly, they are taking it only 4 times a day. And when they are not taking the tablets on time, instead of, why don't you take the tablets on time? Which carries that authority and anger again. Instead, what I would say is, if you are not taking the tablets, as I said, there must be a good reason for that. Tell me, what is it? Do you get any side effects when I do that, when you take it on time? You tell me and we'll sort the problem out. And then they will tell you the truth. All our medical knowledge becomes useless when the patients do not take treatment the way you ask them to. And even in the UK, they found that only 1/3 of the people strictly adhere to the prescriptions. You can imagine what will happen when we do not get time to explain things properly. So these 3 points I'll mention in preparation. Believe the patient about the pain, correct correctables, and check adherence to treatment. And with that, I'll move on to the next one, where I'll try to explain, Nisha, the 2 important kinds of pain. I'm sure this is unnecessary for all the PGs, but maybe there are some new people there who may still benefit from this. Look, I have shown a picture there, a super simplified pain pathway. On one end, you have the peripheral nerve and the nerve ending. Nerve ending, we call it the nociceptor. The ending where a noxious stimulus creates electrical impulses. which are then transmitted through the peripheral nerve to the dorsal horn of the spinal cord. Nociceptor, peripheral nerve, dorsal horn of the spinal cord, where the impulse gets modified for onward transmission to the brain. When pain occurs by stimulation of the nociceptor, which is what happens when you prick your finger, or when you have an accidental jab or with your knife, or when there is a cancer. The nerve endings stimulated causes nociceptive pain. The other kind of pain, Nisha, that is typically, let me give you an example. Nisha, somebody has a cancer in the upper lobe of the limb, and they have pain here, which is nociceptive, and then the person starts complaining of ache and burning in the arm, and you suspect that the brachial plexus has been eroded. No, Nisha, please go back. Here, the abnormal impulse generation here by the nervous system, anywhere in the nerve, it can be in the peripheral nerve, it can be in the dorsal horn, it can be in the thalamus or brain following a stroke. Whether it's peripheral or central, a pain generating from abnormal impulse generation anywhere in the nervous system is called, yes, Nisha, neuropathic pain. Nisha, next. And unfortunately, we cannot diagnose it by an imaging. The features, okay, let me mention these three. The nature of the pain, not absolutely reliable, but burning, shooting, lancinating, aching, pricking, and so on. Where would the pain be? It would be in the area of distribution of a nerve or a group of nerves. So when the brachial plexus is eroded, it would be all over the arm. But remember, a vascular distribution can mimic it. Even if the brachial artery has got occluded with an embolus, the distribution may appear to be the same unless we carefully map the pain. And third, especially with long-standing neuropathic pain, the dorsal horn cell gets so abnormal that the laminar arrangement fails and there may be abnormal sensations in the area of pain. Nature of pain, distribution of pain, and sensory disturbance. The presence of these, all they may not be there, will guide us to management of neuropathic pain. But we will also remember that in the majority of patients, it is not one or the other, it's a combination. Very often there is a combination of pains. Imagine somebody with a disc prolapse. The local intense pain by muscle pain is nociceptive. The shooting pain down the leg is neuropathic. Similarly, remember that there can be combinations, and therefore the management will have to be as both when there is a combination. Both the management for nociceptive and neuropathic will have to come in. Now, unfortunately, neuropathic pains demand some medicines, some adjuvant medicines other than ordinary analgesics. Next, please, Nisha. So initially, you remember, in terms of preparation, I mentioned 3 points. Now we are going to 3 points that we need to review. What kind of pain is it? Are we missing something? The person with CA pancreas may actually be having a colicky pain. Unless we ask for the details, we'll miss it. And very often, there can be a psychosocial issue worsening the pain. Nisha, there is something happening causing scribbling on the screen. No, please go back. No, go back. No, next one. Sorry, not back, next one. I'm just giving the link. Nisha, I suppose we'll be giving the presentation for all the participants later, so that they can see it later. I am giving the link for a TEDx talk by one of my colleagues, where she beautifully explains how total pain works and how relief from a social issue actually relieves a physical pain. With that, we can move on to the next slide, Nisha. I don't know how those graphics came into the screen, Nisha. I'm seeing some scribbled lines, but that's okay. We live with it. So the review step 2 is to think of things other than medicines. A common complaint against doctors is that we are all usually too drug oriented. How about interventions? That person with pancreatic pain who does not respond well to analgesics may actually respond beautifully to a silly.
Hello, Dr. Raj.
Hello.
Hello. Can we hear?
It doesn't.
Hello, sir.
Yes.
You are not audible clearly.
No.
Can you please repeat
Oh.
the last part?
Okay, I'll stop my video for a minute if I'm not audible. Can you hear me now?
Yes. Yes.
Yes, sir.
So I was saying that any interventional procedures like neurolytic blocks may become necessary, and simple non-pharmacological measures, including physiotherapy, without causing pain. And I just gave a show here as an example, transcutaneous electrical nerve stimulator, which doesn't usually relieve pain adequately, but which does give significant extent of suffering in some kinds of pain. So in this step, I am recommending that we will review non-pharmacological measures and interventional procedures where appropriate. And the third review step, Nisha, is that I would recommend is reviewing the choice of the medicines. Okay, we have given a prescription. We have checked whether the patient is taking them regularly. Now, can I take a minute and ask the postgraduate trainees to look at the prescription and see if each prescription is rational? Let us say that this patient is about 50 kg, emaciated, but 50 kg. Is the one by one. Please respond by chat. Is the dose of paracetamol okay? Is the frequency okay? 500 milligram TID. That's what mostly gets prescribed.
Hello, sir.
I'm waiting for somebody to respond, Nisha. I am waiting for the postgraduate students to respond by chat. So, okay, what's wrong with the paracetamol? It is inadequate dose and inadequate frequency. At least 12 milligrams should be prescribed. 12 to 15 milligrams may be okay for some days, sometime, but 12 milligram per kg would be optimal. And TID is simply not enough. Paracetamol has a duration of action of 6 hours or less. It has to be taken 4 times a day. Okay, the morphine frequency may be okay, but if you are giving it by the clock, very clearly the bisacodyl should not be SOS. It should be regular. And imagine that patient with CA bronchus, upper lobe, and neuropathic pain down the arm is concerned. Would you consider the choice of gabapentin 200 milligram BD appropriate? Some response by chat, please.
So gabapentin should be given 300 milligrams OD initially, sir. Then 300 milligrams BD for 2 days. Then 300 milligram TDS for 3 days till adequate pain relief is reached.
So thank you. You are recommending a gradual increase in the dose, which is quite totally agreed. If you are increasing the dose, it should be gradual, because a sudden increase will cause intense tiredness. Having said that, I mean, we will also remember that the optimal dose often is something that the patient will not tolerate. 1,800 milligrams to 2,700 milligrams is recommended. My God, somebody like me would be practically bedbound if I take that much. But there is another issue. I don't know. Next, Nisha, next one. I am putting my video back on so that I can directly interact with you. But if I am become inaudible, please tell me, and I'll stop the video. I don't know if you have seen the WHO guidelines for cancer pain in 2019. If you have not seen it, you must. I have given the link there. Please, even if you just look for WHO cancer pain guidelines 2019, you will find it. There is a bold statement: amitriptyline is first line treatment for neuropathic pain and cancer. Amitriptyline, our poor, humble, inexpensive amitriptyline, still stands as first line treatment. But no medical representative ever comes to you and tells you about amitriptyline. Has anybody? Not unless they are creating an expensive combination.
No, sir.
So this is the issue, because amitriptyline is inexpensive, and of course it causes tiredness. So does gabapentin in the recommended dose. And very clearly, they have taken gabapentin and pregabalin off the recommended list for neuropathic pains, because even 2 years earlier, it was found that the evidence generated for gabapentin and pregabalin were fraudulent, fraud committed. So they are taken away. Just remember this. I am not saying that gabapentin is a useless drug or pregabalin is a useless drug. But you will also remember that because you prescribe gabapentin, many children in many poor people's families will be going hungry. So with that, where were we? We were saying that it will be good to review the medicines. If you give the appropriate dose and appropriate frequency, sometimes the pain that was not responsive earlier may become responsive. I'm sorry that there is this background noise, and maybe I'll make one more request to everybody. Please mute your microphones, and if there are questions, please answer to them by chat. Okay, Nisha, can we move on?
There is one question I wanted to ask, sir. Hello?
Yes, Dr. Francis.
Yes, sir. This is regarding anti-inflammatory drugs, sir. We have not used brufen or Voveron in this at all. Is there any role for anti-inflammatory drug in pleuritic pain or anything of that sort, sir?
Dr. Francis, very valid and important question. Certainly there's a role. Oh, absolutely. Absolutely. Nisha, this means that I am going to have to take 2 minutes more than I planned to, which will eat up into the question time, but this is a question answer time that's happening, so that should be okay. Doctor, if there is somebody with cancer pain, as a first line, I will try paracetamol. If there is a strong component of inflammation, see, in the person with the upper lung lobe lesion, there is a process of inflammation because cancer causes inflammation. NSAIDs other than paracetamol have a role, but I don't make it the first line drug because of its complications of gastritis,
Yes, sir.
the renal failure, particularly the renal failure, and
Okay.
we know that just 1 day of poor hydration, just
Yes.
1 day of poor hydration is enough to destroy the kidney. In
Okay, sir.
India, the commonest cause for acute renal failure is iatrogenic. And
Okay,
among
sir.
the major medicines, the commonest are NSAIDs.
Yes,
So
sir. Yes, sir.
every time I give an NSAID, I ask whether they have a predisposition to gastritis. I ask them whether they have any bleeding tendency. And I always tell them, never take this medicine if you cannot drink enough water.
Okay.
Okay, Dr. Francis, thank you for the participation.
Thank you, sir. It was very nice, sir. It was very,
Sush-
very informative. Thank you, sir.
Sushma has sent a message asking me not to take questions till the end. So hereafter, if I ask a question and wait, please respond by chat, and we'll have the question answer session vocally in the end. Thank you, Sushma. And thank you, Dr. Francis.
Thank you, sir.
So we are going on to the next step. 3 steps in initial review, preparation, 3 steps in review. Now we are going to modification of the drug regime. If somebody is not responding to the ladder with morphine, the commonest cause would be that they possibly have a genetic predisposition, which will cause more metabolites in them. M3-glucuronide is the one that is always blamed. We do not have clear evidence that M3-glucuronide is the culprit. We know that M6-glucuronide contributes to analgesia. So if there is no metabolism, morphine molecules themselves will cause analgesia. But that will not happen. There will be metabolism. So M6G produced in the liver contributes to analgesia. And it is suspected that morphine 3-glucuronide may be responsible for many other side effects, including neurotoxicity. The exaggerated drowsiness, the delirium, the myoclonus, etc. Now, it is also known that some people, maybe 10 to 20% of human beings, this may be more in some countries and less in some countries, but ethnically, some may have a greater predisposition to having more morphine 3-glucuronide. So they will create more M3G causing neurotoxicity. Can you think of some way of avoiding this? Well, I am going to mention 2 ways of avoiding this. Next, please. So if your, Disha, next slide. So if your patient on morphine is not responding well, how can we reduce the metabolites? Next, please, Nisha. We do have 2 other opioids belonging to step 3 of the ladder. Step 3 of the ladder, we have 2 orally, morphine and methadone. Fentanyl, transdermal and injectable. These are alternatives. The patient who does not respond to morphine may respond to these, but fentanyl on an average is about 150 times more expensive than morphine. It's a sad, sad thing that about 3 times as many hospitals have fentanyl than have morphine. Everybody stocks fentanyl. Very popular. That's not a good time, measure for initiating analgesia, and it's too expensive for majority of our patients in this country. But methadone is inexpensive. I think there are people, I mean, I'm sure all 3 institutions conducting MD courses will be using it frequently. But for the others, please remember that link I have given is to a supplement to Indian Journal of Palliative Care that between Dr. Sushma and Dr. Naveen Salins they took the initiative to create it in 2018. This whole supplement is available for free download, and it will tell us how to use methadone. If you can get morphine, you can get methadone also, same law controlling them. But it is a narrower margin of safety. It has to be studied and used carefully. So changing from morphine to another opioid is a solution. And methadone is available all over the country. It's the company will sell it, and you only have to make the order. And anybody who finds any difficulty, please contact Dr. Sushma or I, and we can get the medicine. Next, please. So changing the opioid is to methadone is an easy thing to do, but there's another way. This may mean in our country that we may have to admit the patient. Instead of giving it orally, give it by injection. If you give it subcutaneously or intravenously, we are bypassing the liver so that there are less of metabolites. And this is not only theory. We do this and we do see it working, not all the time, but much of the time. The patient who gets delirious with oral morphine seems to do so well with injectable morphine. That's possibly because avoiding first-pass metabolism in the liver causes less of M3 glucuronide or whatever is causing the problem and gives better analgesia. So two measures in management I have mentioned here in drug management. One, switch over to methadone or to fentanyl for the rich person. And or two, if they cannot do it, admit the patient and give the morphine parenterally. You can give it at home. They do it all over the West. But there is a nurse going to the patient's home every day and changing the syringe. What we do sometimes when we cannot admit the patient is to give a syringe with morphine loaded to the family member, put in a butterfly needle, ask the family member to push in 1 ml every 4 hours. Is that legal? There is no law preventing it. I won't give ampules, that is too dangerous. Only diluted medicine in a syringe. And Dr. Stanley McCadden, many years back, took the initiative to prepare a position statement by Indian Association of Palliative Care, which says that self-administration of medicines by the patients are permissible. So we, I think, are adequately protected. The next issue, there are a few questions. I think as Sushma advised, we'll go to them together at the end. Nisha, can I have the next slide, please? The third point in revision of drug management is to treat central sensitization. I fear I have to take a couple of minutes to explain what is central sensitization. Now, we mentioned this earlier. There is a nociceptor, peripheral nerve, and dorsal horn of the spinal cord. What happens in central sensitization? Nisha? Nisha, next. So is sensitization of the dorsal horn of the spinal cord so that impulses going there from the periphery will cause more and more and more of pain. Because if one impulse goes from the periphery, after it is sensitized, 10 impulses or next week 100 impulses will be going to the brain. That's not the only part of sensitization, it's also disorganization, reorganization of the dorsal horn. We don't have time to go into that. But this phenomenon causes poor response to analgesics. Nisha, next one. And it is mediated by the neurotransmitter N-methyl D-aspartate. And every anesthetist here, and certainly all the PGs will know What is the commonest NMDA blocker that is used? Next, please. The NMDA blocker that is commonly used is ketamine. Ketamine, the anesthetic agent, used in tiny doses, usually for 3 to 5 days. I have given the dose, I am not reading it out now. Usually given for 3 to 5 days, will quieten the dorsal horn. And we can use a syringe pump, the picture that I have shown there, but that's not mandatory. If you don't have an access to a syringe driver, Nisha, next one, we will use ordinary syringe and inject it periodically. Only thing is the side effects may be more because they will be peaking in the medicine more irregularly. But it is given ordinarily by injection. But next, please. Oral ketamine can be used. This poor lady with intense neuropathic pain arising from her untreated oral cancer could not have got admitted at all. We gave her oral ketamine for a few days. We don't have a oral preparation, we use the injectable preparation. Norketamine is believed to be pharmacologically active, and that is also believed to act longer. So oral may actually work better, but it does cause more vomiting. You will need an antiemetic, and it's bitter to taste. We just use the injectable medicine, diluted and sweetened before giving it. And the anesthetist here will note that this dose recommended is only about 1/10 of what they would be using in the operation theater to anesthetize somebody. Next, please, Nisha.
Dr. Rajagopal, just a minute. Dr. Francis, your mic is not muted. 4 people have not muted their mic. Please immediately mute your mic. Sorry, Dr. Rajagopal. Please
No
continue.
problem.
ma'am.
Thank you.
Yes, ma'am. Definitely, ma'am.
So, oral ketamine, I'll repeat, is a medicine that's available. We can use it, and it has a limited place as an add-on therapy in complex pains which are not easily treated by the ladder if there is central sensitization. Next, please. But we have to remember 2 things. And many of you know the ordinary side effects, the delirium, the dysphoria, the people's feeling lightheaded. All these are known. The marginal increase in pulse rate and BP is accepted. But what is coming to light more and more in the last 10 years is that repeated doses can cause serious liver injury. Next, please. Therefore, if you are using ketamine, as I suggested, for 3 to 5 days or longer sometimes, always check the hepatic function. Don't write liver function tests. More money. Poor people. Just get ALT done before the administration and repeat it every 3 days. And stop the ketamine when it gets elevated. This is not only theory, we see it getting elevated. Next, please. And one more side effect that I must mention is vesicopathy. It, like any other cystitis, there will be burning micturition. The only thing is there will be no fever and there will be no microorganisms grown on culture. This one monitoring is every day to the patient on ketamine, ask, do you have burning micturition? Every day. There is no other way. They may not tell you. And the day they say, yes, we have it, stop ketamine. Because otherwise, it can cause long-standing burning micturition and much suffering. So these are 2 important precautions to be taken when ketamine burst therapy is used. Next, please. And finally, one more possible form of treatment for non-responsive intractable pain, especially when neuropathic, is to give intravenous lignocaine for possible membrane stabilization. Just as in your patient with dysrhythmia, it reduces the abnormal impulse generation. By quietening the nerves, the membrane stabilization prevents abnormal impulse generation, and it may work. Where it works, then you can switch over to an oral antiarrhythmic belonging to the same class, flecainide. It's available. So this is the last measure in the drug therapy that I will mention. So next please, Nisha. What we have gone through are 3 measures to check. Believe the patient about the pain, correct any correctables, and make sure that your prescription is being adhered to. And 3 things to review. Review the nature of pain. Review is the pain to see if it will be amenable to interventions or non-pharmacological measures. Review your prescription. Is every medicine given in the rational dose and frequency? And if yes, there's nothing to be changed there, then you go on to drug management. Switch to methadone or change to parenteral morphine. If it's long-standing pain, we have no way of measuring central sensitization. It's only by suspicion. We'll have to try ketamine, remembering the possibilities of hepatotoxicity and vesicopathy. And carefully with monitoring, we might try lignocaine, and if it works, switch to flecainide. These are the 10 steps that I have recommended. These are not any official steps or from any organization. I just use it because I forget things. I find this mnemonic easy to remember. How effective is flecainide or lignocaine? If you, I don't have statistics. Unfortunately, chronic pain is not easily amenable to double-blind control studies, but sometimes it does work remarkably. Next, please. And I'll stop with this. I have given 10 steps. Can I give you the bad news? Unfortunately, even if you do all this, there will be a proportion of patients who still do not get satisfactory pain relief. And my plea to you is, when we have tried everything and failed, we will have to come to acceptance. We should not keep on pushing the patient to do and do more and more futile things. And patient should not feel rejected. I'll be frank with the patient. I accept, okay, whatever I have tried, I know has not given you enough pain relief. But we are here for you if you need any help. If there is any worsening in the pain, do come back to us. And if you sometimes feel you need to talk to somebody, do come back to us. And when you leave the door open, even if they go to Ayurveda or homeopathy or some expensive interventional pain management, if they need us, because we have left the door open, they'll come back to us. Thank you very much. I'm so grateful to you for listening to me patiently.
Thank you. Thank you, Dr. Raj. Anuja, now we can take question one by one and sir will answer. You
Yeah,
can ask.
Anuja, can you stop screen sharing, please? Thank you so much, sir, for a wonderful. We have some questions in chat. First is, which one is a preferred drug, amitriptyline or nortriptyline?
Thank you for the question. Nortriptyline is actually marginally less expensive, and also side effect profile seems to be better. The only problem is that is not proved by randomized control studies.